Good evening, everybody. I welcome you all to the June chapter of Therapeutic Forum, which is organized by the Sri Lanka College of Internal Medicine to enhance the knowledge and practices on subspecialty topics of practicing physicians. Without further ado, I would like to invite our President-elect, Dr. Madhuvanti Hettiarachchi, to address the gathering.
Good evening, ladies and gentlemen. I warmly welcome you to the Therapeutic June chapter organized by Sri Lanka College of Internal Medicine. And we have started this Therapeutic Forum in 2023, of course, by Dr. Ranga Gunasekara, the physician at Nureli District General Hospital. So he's the one who is moderating today. Today we have got this gastroenterologist from DGH Matara. He's Dr. Kuleesha Kodisinghe. And today he's going to speak to you about transformative therapies in modern gastroenterology. Actually, it will be a very useful lecture for all of us, especially the internists as well as the PG trainees, medical officers, everyone. And I hope that you will gain new knowledge during this next 30 to 40 minutes or so. Over to you, Dr. Ranga Gunasekara, the moderator of today's Therapeutic Forum, and to introduce the speaker. Over to you, Ranga.
Thank you, Dr. Madhuvanti Hettiarachchi. Dr. Kuleesha Kodisinghe, MBBS, MD, consultant gastroenterologist, this General Hospital Matara. He passed out from Faculty of Medicine, University of Colombo, Sri Lanka in 2005 and completed MD training and postgraduate Institute of Medicine, University of Colombo in 2015. He had overseas training in Addenbrooke Hospital, Cambridge University Hospitals from 2015 to 2017. So far, he has over 10 publications and 20 abstract presentations. Over to you, Dr. Kuleesha Kodisinghe.
Thank you, Ranga, for that introduction. I'd like to thank the College of Internal Medicine as well for inviting me to do this talk today. I hope you can see my screen, Ranga.
Yeah, of course.
Okay. So the topic given to me was beyond diagnosis, transformative therapies in modern gastroenterology. So this shows the areas that I'm going to touch. As you can see, it's a very vast topic. So I thought of actually speaking more by covering everything, speaking more, concentrating more on things that we have available to us, and also something about recent advances, so that these might come to us in the near future as well. So regarding the therapeutic endoscopic procedures, I'm going to divide my talk into 5 subtopics: esophagus, stomach, small bowel, colon, and the pancreatobiliary system. So when it comes to esophagus, the main therapeutic procedures with attention to the esophagus is the variceal banding, stricture dilatation and stent placement, foreign body removal, and therapy for Barrett's lesions. So variceal banding, I think one of the main things very commonly we see in medical wards. So a patient, in a patient suspected with variceal bleeding, the upper GI endoscopy is recommended within 12 hours of the presentation, after the patient has been stabilized. So it's very important, the word after. Studies have shown if you rush into endoscopies, like within the first 6 hours without stabilizing the patient, the mortality is higher. So what you need to do is stabilize the patient and do early endoscopy within 12 hours of the presentation. It is generally recommended to fast for 6 hours and avoid solid foods for 24 hours post-banding. This is more from practice experience rather than solid data. for the fear of dislodging the bands if the patient takes solid foods. A PPI and an antacid with sucralfate is generally recommended after variceal banding because these patients develop, they usually develop a severe chest pain for a few days after the banding because the banding causes ulceration in the esophagus, and that is actually the therapeutic mechanism. When the ulcers heal, the scar tissue is the one that closes the varices. So because of the pain, we tend to give PPI and sucralfate for about 2 weeks after the procedure. A patient who has had variceal bleeding needs a follow-up endoscopy to make sure the varices have been eradicated completely. So if the gastroenterologist has forgotten to give a repeat date for a endoscopy, for a surveillance relook endoscopy, you can ask the gastroenterologist for a date. So actually, this should be a continuous process to make sure the varices are not recurring. The presence of variceal bands does not contraindicate placement of a feeding tube if indicated. So this is a very common problem that we encounter, a patient coming with upper GI variceal bleeding, also having hepatic encephalopathy, and you have to tube feed them. So there's no contraindication to place a feeding tube if you do it carefully, even after the banding. Next up is stricture dilatation and stent placement. So dilatation can be performed for peptic strictures, malignant strictures, post-surgical strictures, post-radiotherapy strictures, caustic strictures, and for achalasia cardia. Stenting is performed for malignant strictures, tracheoesophageal fistulas due to malignancy, for esophageal leaks, for fistulas, and even esophageal perforation, and for refractory benign strictures, and for refractory variceal bleeding. So there's a special kind of stent that you can place for refractory variceal bleeding, which will compress the varices and temporarily prevent the bleeding until you take other measures. So if you do the stenting for benign strictures, it's only for a short time, like up to a maximum of 3 months. By that time, you have to remove the stricture. Otherwise, you won't be able to remove it thereafter. But for malignancy, it's going to be there for the rest of the patient's life. After caustic injection, sometimes we get referrals, whether we asking for an endoscopy. But what is recommended is, if we are doing endoscopy, it should be done within the first 12 to 48 hours. So at least within the first 2 days. And this is actually not for any therapeutic measures, because you won't be able to do any therapeutic measures during this time. It is just to see the area of involvement, because you can actually predict the future complications that the patient might get depending on the amount of the area involved. Other than that, if the 2 days have passed, there's no place for a upper GI endoscopy because there's a risk of perforation. And dilatation, if you are doing dilatation, it has to be deferred for the first 3 weeks. So in the first 3 weeks, you are not going to do any therapeutic interventions. As you can imagine, for a stricture dilatation or stent placement, the coagulation parameters need to be checked prior to the procedure. And routine post-procedure imaging with the chest X-ray or contrast studies or relook endoscopies are not indicated unless there's a suspicion of perforation. So clinically, if there's a suspicion of perforation, of course, you might have to do this, but unless there's clinical suspicion, you don't have to do any post-procedure investigations. Foreign body removal. So if there are certain indications where you need to do foreign body removal as an emergency in the 6 hours. When there's complete esophageal obstruction, complete is where the patient even can't swallow his or her own saliva. So that is complete esophageal obstruction. Or if disc batteries or sharp pointed objects are lodged in the esophagus. Because these batteries, they can corrode the esophagus, and sharp pointed objects and perforate within the limited confinement of the esophagus. So if these two are there, you have to do a emergency endoscopy to retrieve the foreign body. Urgent endoscopy is where you can delay it for the first 24 hours. So the endoscopy can be delayed if there are esophageal foreign bodies that are not sharp, including a footballers, not sharp. And if it's not a disc battery, you can wait. Sharp pointed objects in the stomach or duodenum, you don't have to rush for endoscopy. You can do it within 24 hours. Objects more than 6 centimeters in length at or above proximal duodenum. You can wait for a bit and do, but you have to do it because things of this size won't pass the duodenal bends. So it won't spontaneously go out. So you have to retrieve it, but not you don't have to do it as an emergency. And also magnets, because they tend to erode the bowel. They should be also retrieved, but as a not as an emergency, as an urgent endoscopy. You can wait and see. That is non-urgent endoscopy. You can just wait, monitor, and do the endoscopy only if needed. In these situations, if there's a coin in the esophagus, it can be observed for 12 to 24 hours because the coins tend to pass down and out of the patient with time. And objects in the stomach with a diameter of 2.5 centimeters, these also, smaller objects, these also tend to pass. And disc batteries and cylindrical batteries in the stomach without any signs of GI injury. So if it has passed down to the stomach already, can be observed for 48 hours. And by that time, if it has not passed, of course, you have to take it out. If endoscopy is deferred, the patient should continue a regular diet because we are trying to flush the thing out here. So the patient can continue a regular diet and observe their stools for evidence of passing of the object. And weekly radiographs are sufficient to follow the progression. It might take even 4 weeks to pass out. Therapy for Barrett's lesions. So endoscopic resection is the therapy of choice for dysplasia. The dysplasia, when there's a dysplastic lesion in the Barrett's segment or a early adenocarcinoma, endoscopic resection is the therapy of choice. So this is a short video. We actually have this available to us. There's a special set where you suck the lesion into the this set and then put a band around it. You can see a rubber band here, and then you put a snare and that cut that part out. So this is available to us. So if there are any patients that need this, we can do it. Or not for all Barrett's. If there's dysplasia or early malignancy, we can do this. And endoscopic ablation with radiofrequency ablation is the therapy of choice for high-grade dysplasia and intramucosal cancer when there's no visible lesion. If there's no visible lesion to remove, but in the routine biopsies, if there's high-grade dysplasia, you have to burn it with radiofrequency ablation. And after removal of visible lesion, you have to also radiofrequently ablate the rest of the lesion, rest of the Barrett's, because they can have synchronous lesions in the other areas as well. So this shows the radiofrequency ablation. So you put the ablator, it's like a bulb. You distend it, and then when you apply the radiofrequency current, you can see that whole area has been burned. Moving on to the stomach, the areas I'm going to focus on are hemostasis of bleeding ulcers, blue injection, PEG tube, percutaneous endoscopic gastrostomy, nasojejunal tube or NJ, and we also do balloon dilatation and stenting for the stomach lesions where there's gastric outlet obstruction. So hemostasis for bleeding ulcers. So if the patient has suspected ulcer bleeding, there's the wait period might be a bit longer. So you can wait up to 24 hours. You don't have to do it within 12 hours like in a varicose bleed. There's bit more time you can wait. And again, after the patient has been stabilized. And always Helicobacter eradication needs to be given after ulcer bleed. So when a patient is discharged, you have to give H. pylori eradication to these patients. Glue injection, again, a very common situation we face. What you need to know as physicians, I think, is post-procedure, there's a risk of glue embolization. So the patient can present with symptoms similar to pulmonary embolism because the glue can embolize after the glue injection. PEG tube, a very common situation in our setting. PEG tube is put when regarding enteral nutrition, it's indicated if inadequate oral intake is anticipated for at least 5 to 7 days. So if the patient cannot take orally, you can actually wait for 5 to 7 days if you anticipate that the patient will regain the ability to eat within that period. But if you think that the patient is not going to achieve the ability, then of course some kind of enteral nutrition is needed. And PEG feeding is actually a long-term enteral feeding mechanism. It's not for a short term. So if you expect the problem to last for more than 4 to 6 weeks, then you can put a PEG tube. Otherwise, actually, you can manage with the nasogastric tube, NG tube. And PEG feeding may reduce aspiration, but it will not entirely eliminate it because the food is going to go into the stomach and it can regurgitate. And post-pyloric feeding, called a PEG J tube, where you put a PEG tube and then you have an extension tube where which goes through the pylorus into the jejunum. So the feed will go through the abdomen and then directly go to the jejunum. This will make aspiration less likely. So if aspiration is the main problem, main reason you are putting a PEG tube, it's better to go for a PEG J rather than a normal PEG tube. Relative contraindications for PEG is ascites, which will lead to leakage of the ascites, and neoplastic or some kind of inflammatory vasculars, any kind of disease in the gastric or the abdominal wall will be a relative contraindication. Abdominal surgery, again, a relative contraindication because there might be bowel loops attached to the abdominal wall, which can perforate when you puncture the abdomen. Curative resection, if a curative resection is planned for esophageal cancer, there's no place for PEG because it might adversely affect the future surgical perspective because you are going to puncture the stomach. And as always, coagulation parameters need to be checked. Pre and post procedure antibiotics are generally recommended. So we give 1 hour before the procedure and for IV antibiotics for 24 hours after the procedure, generally augmentin. And there's no absolute time period after which PEG tube should be changed. So we get asked this question a lot. You might have seen this type of PEGs also, dark, become black and shriveled and, but still working. So as long as it's working, there's no need to change this. Some common complications of PEGs, peristomal leakage. So this is a common complication. Usually occurs within the first few days after PEG placement. Most likely occurs in malnourished patients or in diabetics. This happens because of poor wound healing. And placing an external bolster of the PEG tube too tightly. The bolster is this one. If you put it too tightly against the abdominal wall, this can lead to poor tissue blood flow and wound breakdown. So you are supposed to keep a small gap between the wall and the bolster. That is what we do when the patient leaves the endoscopy room. But sometimes we see in the wards, somebody has again tightened it. So there should be about a 5 millimeter slight gap between the two. Treatment should include correction of comorbidities. So you have to correct the malnutrition, elevated blood sugar, and sometimes they are placed for anti-secretory therapies and prokinetics also. As a treatment method, sometimes you can remove the PEG for 24 to 48 hours, allowing the hole to close a bit, and then again place another tube through the same hole. But sometimes PEG will need to be removed and put at another location. peg site bleeding, usually this happens very early, immediately after we put the tube. This is managed by tightening the external bumper against the abdominal wall tightly. But again, because of the previous reason I mentioned, this should be released within 48 hours. Otherwise, the wound, there's a risk of wound breakdown. Granulation tissue formation. This will sometimes bleed also. This can be prevented by preventing excessive tube movement. So the tube, when it's not fed, should be securely fastened to the abdominal wall. If it has occurred, you can give, you can apply silver nitrate and steroid antibiotic. Blockage of the peg tube commonly occurs with what is called buried bumper syndrome. So in this picture, you can see the bumper. That this is the endoscopic view. So the plastic thing, the white thing you see is the bumper, which prevents the peg tube from falling out. This has eroded into the gastric wall. This is because the external bolster has been very tightly applied for a long time, and with time the internal wall bumper has eroded into the abdominal wall, and this can cause obstruction. If this has happened, of course, you have to remove the tube. But other common situation is where the simple blockage of the tube is there. You can flush with warm water, Coke, or a pancreatic enzyme solution. Peg site infection. You have to do a soap culture and give antibiotics. Sometimes a patient might even need surgical debridement. If there's inadvertent peg tube removal, very important situation. If the patient has inadvertently removed the peg and come to your ward, if the peg tube is removed early, if the removed early, like within 2 to 4 weeks of the initial placement, if the patient presents immediately, you may be able to put the peg through the same hole, because the peg tract takes about 2 to 4 weeks to mature. So, but if the patient presents very early, you might be able to put to the same hole. But if the patient comes a bit late, the hole will have closed, and then you might have to put tube some other place. But if it has if the peg has been removed after 2 to 4 weeks after placement, you can assume the peg tract has matured, and freely you can use the same hole to put the peg tube. So if the patient has come to the ward after an inadvertent peg removal, the first thing you need to do, if the patient has, if you think that the tract has matured, like the peg has been put for 2 to 4 weeks back, the tract has matured, you can put a urinary catheter through that hole and inflate the bulb temporarily, not to feed, temporarily, so that that tract is there, so that the endoscopist can later go on and use the same tract to put another tube. Peg care, the patient should be advised on these things. The peg dressing is removed after 24 hours. After that, no need to put any dressing. You can leave it open and exposed. And peg may be used after 4 hours. So after 4 hours, can start feeding. First, flush with sterile water, and then you can commence feeding. Start slowly with a small amount, and then you can build up to a volume of 200 to 400 over 15 to 20, 60 minutes at regular intervals. But if the patient develops bloating, nausea, vomiting, you might have to reduce the rate of infusion. Feeds must be in the room temperature, otherwise the patient can develop diarrhea. Prior to feeding, always you have to make sure the external length of the tubing is at the place that it was there when the tube was put in. Usually in our reports, we mention the external, there are markings on the outside of the tube. We mention the skin level, like 3 centimeters. So it should be always 3 centimeters. If it's like 6 or 7 centimeters, that means the peg has gone in. And in that case, it's not a good idea to feed. So always the patient or the bystander should check it. and there's a medication port. You have to use the medication port to give medicines and the feeding port for food. And the tube should be flushed before and after each feed or medication. And during the initial period, you should advise the patient or bystander to turn the peg 160 degrees at least once a day, so that the peg tract matures nicely. Otherwise, the maturation will be problematic. And as I said, stabilization of the peg is very important. Nasojejunal tube, as I mentioned earlier, the peg is a long-term feeding mechanism, but nasojejunal tube is for short-term. And this is if the patient has some kind of gastroparesis. Because here you are bypassing the stomach, directly putting the tube into it's like a nasogastric tube, but inserted endoscopically directly into the jejunum. So you are bypassing the stomach. So you can put this in patients with severe gastroparesis, severe pancreatitis, who again develop gastroparesis sometimes. And if there's high risk of aspiration for a short time only, you can put this tube because the feed will directly go to the jejunum. This is also available to us. When it comes to small bowel, what I want to concentrate is on the video capsule, which is available to us. So the video capsule is, you might have seen this, it's like a capsule with a camera, the patient swallows it and it records the thing on the way out, and it will pass out. The recording will be transmitted to a device on a vest that the patient is wearing, and it will record everything, and later we can obtain the recording and go through it. So general indications are if there's obscure GI bleeding. So if patient has sort of melena and we do upper and lower GI endoscopy, you can't find anything. Then if the melena is ongoing, you might have to check the small bowel with this. Evaluation of iron deficiency anemia, another common indication where upper and lower GI endoscopy is done and they are normal. And suspect a small bowel Crohn's disease, because you'll be able to see lesions on the video capsule. CT prior to video capsule is needed if obstructive lesions are suspected. So in a patient, if you're suspecting small bowel obstruction like in Crohn's, you have to always exclude obstruction prior to the video capsule via CT, because otherwise the capsule can lodge at the place of the obstruction and patient might have to go for a surgery. Preparation similar to colonoscopy, you have to give the bowel prep. And regarding patients with small bowel Crohn's disease, before going for enteroscopy is an endoscopy looking into the small bowel, which is a bit difficult to perform. What we usually do is do the video capsule and see where the lesions are. If the lesions are like in the proximal small bowel, then we can do the enteroscopy through the mouth. If the lesions are like close to the ileum, then we can do the enteroscopy from lower side. So to plan which side we are going to do the enteroscopy from, we can do a video capsule endoscopy and find out. When it comes to the colon, I want to concentrate on polypectomy and also EMR ESD, that is endoscopic mucosal resection and endoscopic submucosal dissection. All these are available to us. Hemostasis of bleeding, stricture dilatation, and stent placement. When it comes to polypectomy, polyp assessment is very important. So we have this modality on our endoscopes called NBI or narrow band imaging. This is a special filter which we can activate on the endoscope, which will filter out the red spectrum of light. And with the blue and green, they usually that spectrum is usually absorbed more by red cells, by hemoglobin, and thereby when you put the NBI mode on, you can see a sort of the blood vessels very clearly. So you can see the contrast between the mucosa and the blood vessels very clearly. And as you know, in a malignancy, angiogenesis occurs. So there are a lot of abnormal blood vessels. So this helps to identify polyps and malignant lesions, which will contrast from the surrounding areas. So you can see the NBI colonoscopy. On white light, you can see this lesion vaguely, but it can be clearly seen in NBIs. And actually with NBI, there's this nice classification where we can predict the histological variety of the polyp also. Whether it's hypoplastic adenoma or malignancy, we can predict by the NBI, which will aid therapy also. So if it's adenoma or hypoplastic, we can remove endoscopically. But if it's sort of looking malignant on NBI, we don't remove the polyp, we refer to a surgeon. So polypectomy, if the patient is on clopidogrel and anticoagulants, they need to be stopped prior to the procedure. Complications, you need to know of these complications. I think there's a risk of bleeding 0.5 to 2%. The bleeding can occur actually even up to 2 weeks after the polypectomy. So you have to advise the patient to keep on looking at their stool even after they are discharged. Perforation, there's a less than 2% risk. Post-polypectomy coagulation syndrome, a bit of a rare entity, where it's a manifestation of peritoneal irritation, where we use electrocautery to cut the polyp. There's peritoneal irritation, and the patient can present with symptoms similar to perforation, but there's no perforation there. It's just a reaction. And stricture formation, if you have removed a very large polyp, there's a risk of stricture formation. EMR, that is endoscopic mucosal resection. What we do is we inject some solution, normal saline or some solution under the polyp to lift it up so that the polyp is separated from the muscle layer. And then we put a snare in and then we cut it out. This is to prevent reduce the risk of perforation. That is endoscopic mucosal resection. Endoscopic submucosal dissection is bit similar. Again, you lift the polyp up, but here you do a dissection. It's not we don't put a snare in and cut it. We dissect under the polyp with the electrocautery device, slowly cut the layers under the polyp and then retrieve the lesion. This can be done for very large lesions. I don't think you need to know the exact details, but what you need to be aware is that certain polyps need post-polypectomy surveillance, especially if the polyp is, even if it's not malignant, if it's a adenoma, but if the polyp is very large, the patient might need post-polypectomy surveillance. So these are the hemostatic mechanisms that are generally available to us. Injections such as adrenaline, thermal therapies like argon plasma coagulation and heater probes, mechanical therapies like clips and banding, and contact therapies like hemospray. Hemospray is a solution, actually it's like a spray that we can instill through the endoscope, which will immediately coagulate upon contact with any kind of biologic material. So when we spray it onto a bleeding site, immediately it will cause a sort of a layer over that site and then temporarily prevent the bleeding. You can use this in very severe bleeding where you can't find a sort of exact place of bleeding to arrest it. You can just spray over it so that you can buy time until you go in and again and exactly deal with the exact lesion. Moving on to the pancreatobiliary system, ERCP, I'm going to divide this into biliary and pancreatic. With ERCP, stone extraction, biliary stricture, dilatation and stenting, and bile leak management are the areas that we are going to touch. With the bile leak management, it's similar to biliary stenting, because what you do is put a stent in through the past the leaking site. When it comes to ERCP, there's no such thing as diagnostic ERCP anymore, because we have better measures like MRCP and endoscopic ultrasound. ERCP is now reserved for therapeutic intervention, because there's ERCP is not without any risks. So we don't do diagnostic ERCPs anymore. It's only for therapy. So biliary stone extraction. A small video which will show this shows actually the stones when you do a X-ray of the patient during the endoscopy. So what we do is we go in and we make a cut in this is the ampulla. We put this device in and make a cut there so that we can retrieve the stone. And then we put a balloon or this kind of device, and then we pull the stone out. So that is what we do. So the stone has now come out. So just pull it out. So if there's any obstructing calculus in the common bile duct, this is the procedure that you have to do. Biliary stricture dilatation and stenting. So this shows a case where there's a stricture. So the cholangiogram, this one shows dilated intrahepatic bile duct. So this is intrahepatic bile ducts. This is the common bile duct. So ducts are dilated because of the stricture. So we are passing a stent through the papilla, and now the stent has been deployed. So this actual procedure where you put two metal stents, and this shows the stents in the bile duct. So you can see this is the stent. So all these are available to us. When it comes to pancreatic part of the ERCP, you can do ERCP for chronic pancreatitis, recurrent acute pancreatitis, and pancreatic duct leaks. ERCP, is there a place for ERCP in acute pancreatitis? Only two indications: if there's ongoing biliary obstruction or ongoing cholangitis. So ERCP for acute pancreatitis is only for biliary indications, not for pancreatic indications. You don't go and mess around with the pancreatic duct in these patients. You just need to, if you need to relieve biliary obstruction, or if the patient has ongoing cholangitis, then you might need to do it. No choice. You might need to address that issue with the ERCP. In chronic pancreatitis, pancreatic duct stenting can be done, but it is a measure to relieve pain. So not all patients need this. If the pancreatic duct is dilated, usually due to a calcified stone obstructing the duct, and if the patient is having pain, then you have to do a ERCP to relieve the pain by putting a stent into the main pancreatic duct. Surgery is the other option and actually might give better long-term pain reduction, but due to the invasiveness, generally endotherapy might be preferred in these patients. So in this photo, you can see these are the calcifications, and this is a stent has been put in. This is the when you put the dye in, you can see the pancreatic duct this is the pancreatic duct which has enlarged, and then you can put a stent in to drain the pancreatic duct into the duodenum. But patients may need pre-procedure ESWL, that is external shockwave lithotripsy, like in a renal calculus, because unless you break down this calculi with ESWL, you might not be able to put the stent in, because these might be obstructing the passage of the stent. So might need pre-procedure ESWL also. What is the place of ERCP in recurrent acute pancreatitis? If a patient has pancreatic divisum, you have to do a minor papillotomy. That is, in pancreatic divisum, the majority of the pancreatic juice is flowing out of the minor pancreatic duct, minor papilla. So normally in a normal patient, the CBD and the main pancreatic duct join and come out of the major papilla. But in patients with divisum, the pancreatic duct main drainage is through the minor papilla, a smaller opening. And because of that, the smaller opening, there's obstruction there. And because of the obstruction, they can get inflammation. What you do is you make a papillotomy, that is, you make a cut in the minor papilla so that you relieve the obstruction. Pancreatic duct leaks. This photo shows some contrast leakage from the pancreatic duct. So this is some contrast leaking from the pancreatic duct. What you do is you can put a stent to across the leak to prevent further leaking. So this happens sometimes in patients with acute or chronic pancreatitis, where they present with pancreatic ascites or a pancreatic pleural effusion because of the leakage, and we might have to do this ERCP in these patients. ERCP complications, bit important to know. Pancreatitis is the most feared complication, can occur in about 5%. Hemorrhage, perforation, infections like cholangitis, and small risk of mortality also. And endoscopy and sedation related complications can occur because we do this commonly under propofol sedation. So sedation complications also can be there. So post ERCP pancreatitis, when the patient comes back after the ERCP to the ward, we generally do a amylase after 24 hours. You shouldn't do it within the first, there's no point of doing it within the first 24 hours to diagnose pancreatitis, because inadvertently it will be elevated. But if after 24 hours you do it, and if it's more than 3 times upper limit of normal and the patient has abdominal pain, that indicates post ERCP pancreatitis. But you can prevent, you can reduce the risk of this occurring if you put NSA suppository before the ERCP procedure. So this is something we commonly do, 100 milligram of diclofenac or indomethacin suppository before the procedure. Moving on to the recent advances, there's a lot to talk about. Some we have in our setting also. So sort of up to this level about we have in our practice also. Anti-reflux procedures, POEM, that is for oral endoscopic myotomy, endobariatrics, recent advances in ERCP, EUS, artificial intelligence, like in all other situations, pill endoscopy and robotic endotherapy. So anti-reflux procedures. What we did earlier for anti-reflux was surgery. As in reflux surgery was the surgery was to close the lower esophageal sphincter with an open or laparoscopic surgery. But now we have other options which we can do endoscopically. So this is transoral incisionless fundoplication called GERD-X. In Sri Lanka, we have done several procedures, but the problem is this device is very expensive. So this is the inverted view of the stomach, retroverted view. So this is the gastroesophageal junction from the stomach side. In this procedure, what they do is drag the mucosa into this device, and this device has a clip at the end. It's like a stapler. So you put a stapler, thereby tightening the gastroesophageal junction. Endoscopic radiofrequency ablation or STRETA. Here radiofrequency current is applied to the lower esophageal sphincter, and because of the current there will be some fibrosis in that area, which will with time close the lower esophageal sphincter a bit, thereby reducing the reflux. POEM. We have this in Sri Lanka. In fact, now this is the therapy of choice for achalasia cardia. Rather than surgery, we can do is endoscopically for oral endoscopic myotomy. Here, what we do is inject some submucosal saline into the lower esophagus like in the mid-esophagus, and then we make a cut in the esophagus and put a balloon and dilate the cut, because what we are going to achieve is we are going to make a submucosal tunnel here. So we have made the tunnel here now. So on the left side is the mucosa, on the right side is the muscle. So we are going between the mucosa and the muscle here, submucosally, and we dig the tunnel up to the lower esophageal sphincter, where we find these muscle fibers, which is the reason for the achalasia. So these fibers we need to cut to release the pressure at the lower esophageal sphincter. So you make the cut there, and then releases the pressure, and then you have completed the myotomy. You pull the endoscope out through that submucosal tunnel, and then put some clips and close the mucosal defect that you have done in the esophagus. So this is very effective for patients with achalasia. Endobariatrics. So bariatrics is not only surgery anymore. So we have options for weight loss as well through the endoscope. Intragastric balloons. Here what you do is you put a balloon into the stomach through the endoscope with the end of the endoscope, and you dilate the balloon. This will reduce the volume of the food that can be accommodated in the stomach. So they will have satiety. Patient will have satiety, and later on, after about 1 year, after the patient has lost weight, the balloon can be actually retrieved and taken out. So these balloons are available in Sri Lanka, but not in the government sector. I think it will cost around 2 to 3 lakhs. But this is, if the patient can buy it, the procedure is not very difficult. So, endoscopic sleeve gastroplasty. Here, you might have heard of surgical sleeve gastrectomy, where a part of the stomach is cut and taken out. It's a restrictive procedure to take a part of the stomach out so that the patient has early satiety. Similarly, with the endoscope also we can do that. So what they do is put some sutures in. There's this special device which is connected to the endoscope, and put some sutures in, and then with the sutures we can close a part of the stomach out. So if you see this, so this part of the stomach is still there, but it's not working anymore. So you with the sutures, we have reduced the effective volume in the stomach. The benefit versus the surgery is that when you don't need it, if the patient doesn't tolerate it anymore, you can cut the sutures and you can go back to the original situation. But with the surgery, you won't be able to do that. Duodenal mucosal resurfacing. It's a very advanced procedure. We don't have this to us in Sri Lanka. What is done is they ablate the duodenal mucosa with a hot balloon. And by that, after some time, there will be resurfacing of the mucosa, and this will change the hormonal balance, because a lot of these metabolic syndromes are caused by hormones that are secreted due to the food in the duodenum. So this will reset the balance. And this has been found to reduce the incidence of diabetes also. So actually, maybe a cure for diabetes. Recent advances in ERCP. Spyglass system is where through the endoscope, we can put in another endoscope. We call it a baby endoscope through the main endoscope, and we can directly go into the bile duct. So with the normal ERCP, we can't look into the bile duct. We have to stay close to the papilla and then do the procedures, everything through the papilla. But in spyglass, you can directly go into the bile duct and do procedures within the bile duct. And this shows a spyglass view. So this is actually the spyglass view. This is the endoscopic view. This is the spyglass view inside the bile duct, and there's a stone and we can do laser lithotripsy. So we can introduce a laser probe and then apply laser. And as you can see, with the laser beam, the stone is disintegrated. So this procedure is available to us in Sri Lanka. Intraductal ultrasound, where you put a probe with the ultrasound probe into the bile duct, and within the bile duct you can see lesions surrounding the bile duct. So this is a lesion within the bile duct, and you can see some lesions surrounding as well. Endoscopic ultrasound, available to us again in some major hospitals. Very useful in some situations such as pancreatic pseudocyst drainage. So in chronic pancreatitis, when there's a pseudocyst, you don't have to do surgery anymore. You can drain it with the endoscope. So what you do is, this is the ultrasound. So endoscopic ultrasound is, you have a ultrasound probe at the end of the endoscope in this situation. And this is the endoscopic view you see, and this is the pseudocyst, and you can see a puncture happening here. So this is a puncture. This needle is put in through the stomach. So we have made a hole in the pseudocyst here through the gastric wall, and this is the hole, and you can see the pseudocyst fluid draining. And then we put a balloon in and dilate that hole, and then we can put a stent in. So now the part of the stent will be inside the pseudocyst, the rest will be outside in the stomach cavity, and the pseudocyst fluid will drain into the stomach. EUS is helpful to take FNACs, FNAC biopsies. Here you can see a pancreatic mass again with in the endoscopic view, and you can put a needle in and take some biopsies. Celiac plexus block for chronic pancreatitis in patients with having severe pain. You can put some alcohol in and cause a celiac plexus block. Again, you can do it with the EUS scope. Puncture the gastric wall, and then you can put alcohol to this area to block the celiac plexus. And some advanced procedures can also be done with the EUS, such as EUS ERCP rendezvous technique, where you can't put the if there's some blockage at the complete blockage at the duodenal papilla, and you can't put the guide wire in through the papilla, normal mechanism. What you do is you use the EUS, and you identify the dilated bile ducts, and then puncture the dilated bile ducts through the liver, and then put a guide wire, and then direct this guide wire through the duodenal papilla into the duodenum, and through that guide wire subsequently you can put using that guide wire you can put do the normal ERCP. EUS guided hepaticogastrostomy, again EUS guided procedure, where you can put a stent directly from the stomach. This shows the stent directly from the stomach into the bile ducts, because you can visualize the stomach through the EUS scope in the stomach. So this is the dilated bile duct, and you can puncture it through the gastric wall, and then directly drain the bile ducts into the stomach. So this is the stent, and you can see the bile draining here. And you can do the same for gallbladder also. You can directly drain the gallbladder into the duodenum with the EUS scope. You can because you will be able to visualize the gallbladder properly if you put the scope into the duodenum, and then you can make a puncture and put a stent there. Artificial intelligence has come to the fore in endoscopy as well. Now it's aiding polyp detection and characterization. You can see this this endoscope has the polyp detection algorithm, and you can see it's saying it's a hyperplastic polyp. The polyp will be highlighted when you do the normal colonoscopy. Automatically it will highlight the polyps. So there's another polyp here, it's highlighting the polyp, and then it will detect the polyp and also characterize this as well. So it's saying it's a neoplastic polyp. So these are available in the latest endoscopes. Characterizing Barrett's lesions. Again, a bit similar. This is the lesion that we are concentrating on here. This is the Barrett segment, this is the lesion. And when you look at the lesion, it's saying dysplastic. In IBD, inflammatory bowel disease, diagnosis and disease activity also, artificial intelligence has been helpful now. So with these algorithms, you can when you do the endoscopy, it will give these scores telling you whether there's active disease or there's whether there's inflammation or whether there's healing with the use of artificial intelligence. So even without biopsies, you might be able to diagnose inflammation in the future. Artificial intelligence in video capsule endoscopy. These photos show that this artificial intelligence can detect lesions in the video capsule images also. So it will tell you whether these are erosions or whether there's bleeding and give you the probability of certainness also. Pill endoscopy, very interesting video that I found. So this person swallows this pill, and the operator has this kind of remote control in his hand, and now the pill is in the stomach, and he can move the pill about like a drone inside the stomach, and then you can go around the stomach and see lesions. Robotic endotherapy. So this is a robot with the you can see several surgical instruments also attached to the robot, and these are the end of an flexible endoscope. With this, the operator, it's like a robotic surgery. He'll be outside like this and looking at the screen. He can direct these arms of the robot and then do things like polyp resections. So you can see this with the hands, you can do a resection and remove this part of the polyp. One final slide on anticoagulation in endoscopy, which I think is important. If a patient is on anticoagulation, whether you need to stop the anticoagulation or not will depend on these factors. First of all, you have to see whether this is a low risk procedure or a high risk procedure. Low risk procedures are diagnostic procedures plus or minus biopsy. For biopsy is considered as a low risk procedure. If you do a ERCP, if it's just stenting, it's a low risk procedure. Diagnostic EUS, again, the diagnostic, not therapeutic, it's low risk. In low risk procedures, you can continue clopidogrel. Warfarin also you can continue if the INR is in the therapeutic range. If it's over warfarinized, you have to correct that. But if it's in the therapeutic range, you can continue warfarin. But if it's a high-risk procedure like polypectomy, sphincterotomy with the ERCP, EMR, dilatation, therapy of esophageal varices, PEG insertion, EUS with biopsy or therapeutic procedures with the EUS, in those situations, if the patient is on warfarin, you have to stop the warfarin 5 days before the procedure. But whether the patient needs bridging anticoagulation with low molecular weight heparin will depend on whether the patient is having a low risk condition to give warfarin or a high risk condition for the warfarinization. So if it's a low risk condition, you don't have to stop warfarin. You don't have to bridge with low molecular weight heparin. You can just stop the warfarin. But if it's a high risk condition, you have to convert to low molecular weight heparin and then stop that on the day of the procedure and then do the procedure. In these high-risk procedures with clopidogrel, you have to stop clopidogrel 7 days before the procedure. But if the patient has a high-risk condition, like if the patient has received a drug-eluting stent within the past 1 year, then you might have to talk to your cardiologist and then list the pros and cons and then stop clopidogrel before the procedure. As you can see, no mention of aspirin anywhere. This is because in any procedure, whether it's high risk or low risk, you can continue aspirin. So polypectomy, EMR, PEG insertion, anything can be done on aspirin. So in summary, gastroenterology has evolved beyond diagnostics now. And now we are focusing on minimally invasive and targeted therapeutic interventions. So with these significant advancements, our aim is to achieve better patient outcomes. So thank you. If there are any questions, I'll be happy to answer them.
Thank you very much, Dr. Kodisinghe, for that comprehensive talk on recent advances in gastroenterology. I'm sure that our audience is immensely benefited from the lecture. As I said in the early in the chat box, I'll be sharing the QR code now. You can scan the QR code and fill the Google form so that you will receive the certificate. Can you all see the QR code? Mr. Varunai, that can be seen, right? Hello. Dr. Kuleesha, can you see the QR code?
Yeah, I can see it.
Yeah. This QR code will be available for next half an hour to 1 hour. So after that, this will be automatically deactivated. So you can fill the form and put your email address, and then your certificate will be delivered to your designated email ID. So
Yeah, there are some questions,
yeah,
Ranga. We have
yeah.
time. We can.
Yeah, of course. So the first question is, how long after a banding procedure NG tube can be inserted?
Yeah, I think I touched on this earlier in my talk. There's no time sort of limitation. You can put a NG tube after the banding. It doesn't if a patient needs NG tube. But anyway, you are going to ask the patient to fast for 6 hours. So there's no point of putting NG within the 6 hours. But after 6 hours, you can start clear fluids, and then you can, at that time, you can put NG.
Does radiation proptosis fall under your purview? If so, regarding organ-laced ablation, is it indicated only when medical therapy fails? Once it has been done, can it be repeated again?
Yeah, we do a lot of organ plasma coagulation or APC for radiation proctitis. Now it's not called proctitis anymore because there's no inflammation there. It's called angioectasia now. RAVE, radiation associated vascular ectasia. It's called RAVE now. It's not after medical therapy. It's the main treatment actually for radiation proctitis, and it can be repeated any number of times if the patient needs it. If the patient starts bleeding again, you can do it again.
Continuous feeding through the PEG tube through feeding machine is recommended over the bolus feeding is better for aspiration. Does PEG feed machines available in Sri Lanka?
Yeah, I think this continuous feeding is recommended over bolus feeding. What we commonly do is bolus feeding, because I'm not sure whether feeding machines are available actually. And even if they are available, the patient will have to have, each patient will have to have one machine with them at home. So I don't think it's very practical to us. What we do is bolus, but of course, continuous feeding is better than bolus.
Any new interventions for gallbladder polyps without removing the gallbladder?
As far as I know, I don't think there's anything. To remove gallbladder polyps, of course, I think you need to do a polycystectomy. I haven't seen anywhere that there are any other endoscopic interventions available for gallbladder polyps.
The next question is, what is the recommended time gap to do ERCP after a calculus cholecystitis recovery?
Why we do ERCP in biliary problems is if there is a further obstruction in the CBD. So in addition to the calculus cholecystitis, if there's a gallstone obstructing the CBD, then you have to do a ERCP, but not unless not for pure and simple calculus cholecystitis. If there's obstruction in the CBD, you have to do it. I don't think there's any specific time back, depending on the patient's condition. You might have to do it even if there's ongoing cholangitis due to the obstruction, you have to remove the stone.
Right. The next question is there evidence to use IO ear antibiotic drops at the pig site infection or granular tissue rather than using antiseptic lotions that might minimize selecting out of harmful pathogens like Candida?
I'm not exactly sure about the evidence for using IO ear antibiotic drops. But I'm not exactly sure actually. I have never used these. For a peg site infection, probably it's might be inadequate. It's my feeling. Because sometimes there can be abscess formation also at these sites.
Yeah.
Probably you need IV therapy.
Next question is when to rescope after initial EVBL in varices?
So after variceal blanding, the recommendation is to rescope in 2 to 3 weeks. Because there might be some residual varices, you might have to repeat the banding. General recommendation is 2 to 3 weeks, but depending on the clinical situation, we sometimes change this. But according to guidelines, it's 2 to 3 weeks after a banding.
Next one is when a stent is put to drain the pancreatic pseudocyst, how long it will be there? Will it reduce the gastric acidity in the long run if it is permanent?
After we put the stent in, it's usually, we are not usually removing the stent. Sometimes we remove it, but sometimes actually we put a metal stent also in. So metal stent is going to be there for a long time. Our aim is not to remove the stent, because we have to sometimes do repeat endoscopies. We have to actually go through, we might have to go through the hole in the stent into the sac of the pseudocyst, and sometimes do some endoscopic debridement also. In some patients when there's infection inside the pseudocyst, sometimes you have to debride and take that infected material out with the endoscope. So you go through the hole into the cavity and do procedures. So can take a long time. Our aim is not to remove the stent. There's no place for removing stent. It might be there for a long time. It might fall out. I don't think that there's any problem with gastric acidity. I haven't read anywhere. Even if if it's permanent, I don't think there'll be a problem with the gastric acidity, because with time, probably the question is because pancreatic secretions are basic. Because of it draining into the stomach, it will reduce the gastric acidity, but I don't think it will occur, because after some time the cyst will be dry. So there won't be continuous drainage from the cyst. The cyst will be dry. and so I don't think there's a problem with the acidity.
What are the treatment options for GI AV malformation in Oslo-Weber's disease?
So if it's the AV malformations are limited, we tend to do endoscopy wise, we tend to do APC, other plasma coagulation. But if it's very extensive, it's probably not going to be very practical. If it's limited, of course, we can do APC endoscopically. But there are some, I think I have read somewhere that there's a place for bevacizumab. There's a monoclonal antibody which you can use for AV malformation. I'm not sure whether it's freely available to us. But what we can do is endoscopically is do APC, organ plasma coagulation.
Next one is, are there any contraindication for gastric balloon insertion for weight reduction?
Contraindication wise, I mean, if I don't think there's any absolute contraindications, but there might be some relative contraindications because there'll be some limitations to the weight loss that this can achieve. So if it's like a great, or if the BMI is very high, you might not be able to achieve what you want with a pure and simple balloon. Because you can't keep the balloon in for more than some balloons are there for you can keep for 6 months, some you can keep for 1 year, but this is not a sort of a very long term procedure. So if it's a very sort of very obese person, you might have to go for something like if you are doing endoscopy, you might have to go for something like a sleeve gastroplasty. Rather than a balloon, but I don't think there's any sort of absolute contraindications, but probably some relative contraindications like that.
What are the treatment options available for GAVE?
GAVE is gastric vascular ectasia. There are two main treatment options, organ plasma coagulation, APC, and sometimes we do banding also. So along the GAVE lines, we put multiple bands. Again, the same mechanism as in variceal bleeding when an ulcer occurs, and when the ulcer heals due to the scarring, the GAVE will sort of the vascular ectasia will heal. So two main endoscopic options are those. There's no place for beta blockers because the mechanism of GAVE is completely different from portal hypertension. So it's the portal hypertensive gastropathy and the varices are due to portal hypertension. This is not due to portal hypertension. This is due to and vascular ectasia. So there's no place of giving beta blockers here. But endoscopically, you have those two options.
In the absence of any more questions, I would like to thank Dr. Kodisinghe for this interesting and comprehensive lecture on behalf of our audience. And I'm sure our audience is benefited immensely with the information that he has shared with us. Thank you again on behalf of the Sri Lanka College of Internal Medicine and the Council to Dr. Kuleesha Kodisinghe. And we will meet with the next chapter in July 12th with renal replacement therapy. Thank you all. Good night.